Comparison of quadriceps to hamstring strength ratio in patients with osteoarthritis of knee and healthy adults. Abstract background. Osteoarthritis is the most common degenerative joint disease affecting the weight-bearing joints, knee being the most commonly affected. Quadriceps weakness is found to be one of the factors associated with osteoarthritis of knee, along with other contributing factors like age, heredity, biochemical changes in articular cartilage, obesity, and biomechanical compressive loads that lead to joint damage. Many studies in the management of osteoarthritis of knee emphasize on the strengthening of quadriceps. However, little attention is given to the hamstring muscle. An optimal quadriceps to hamstring ratio is required for effective functioning of the knee joint, which is not studied adequately in the literature. Objectives. Weakness is said to be one of the risk factors for the onset as well as the progression of osteoarthritis. Weakness of the muscles around the knee joint thus need to be evaluated in details as it can be easily ameliorated as compared to other non-modifiable risk factor like age or gender. Method. It is a cross-sectional observational study with a total of 132 subjects, 66 patients with bilateral osteoarthritis of knee and 66 age and under matched controls. The quadriceps and hamstring isometric strength were assessed using the baseline hydraulic handheld dynamometer. The radiological severity of a knee joint was assessed by a senior radiologist of the institute using the Kellgren-Lawrence scale, which was correlated with the QH ratio. Conclusion. The ratio of isometric strength of quadriceps to hamstring is significantly lower in patients with osteoarthritis of knee as compared to healthy adults. There is no correlation of quadriceps to hamstring strength ratio and radiological severity of osteoarthritis of knee. Keywords: knee osteoarthritis, quadriceps to hamstring ratio, handheld dynamometer, Kellgren's Lawrence scale. Osteoarthritis is a degeneration of articular cartilage and underlying bone, occurring most commonly in the weight-bearing joints, knee being the most affected. Osteoarthritis has a prevalence rate of 17% to 60.6% in India, and its incidence increases with age, making it a major contributor to disability in the elderly. Women are more affected and burdened by osteoarthritis of knee. The incidence of knee OA increases by age and further increases with longer lifetime and higher average weight of the population. The most common symptoms are chronic pain and joint stiffness, swelling, and muscle weakness. Osteoarthritis of knee is widely done using the Kellgren-Lawrence scale. The Kellgren and Lawrence system is a common method of classifying the severity of knee osteoarthritis using 5 grades. This classification was proposed by Kellgren et al. In 1957 and later accepted by WHO in 1961. Many factors contribute to the development of knee OA, including heredity, biochemical changes in articular cartilage, age, obesity, and biomechanical compressive loads that lead to joint damage. Along with these factors, quadriceps weakness is found to be associated with knee osteoarthritis. Quadriceps and hamstring are the muscles that surround the knee joint and have a key role in maintaining the dynamic stability of the knee joint. Adequate strength of quadriceps and hamstring is necessary for fundamental activities of daily living such as rising from chair, squatting, walking, and climbing steps. Both muscle groups stabilize the knee joint and protect it from stress. Potentially could contribute to increased impulse loading of the knee joint. The quadriceps muscle also is the primary dynamic stabilizer of the knee in the sagittal plane. Therefore, it is possible that weakness of the quadriceps, either absolute or relative to the hamstrings, may adversely redistribute compressive and shear stress at the knee joint. An optimal quadriceps to hamstring muscle torque ratio balances the muscle forces around the knee joint, contributing to normal joint mechanics. A low ratio might affect the functioning of persons with OA and the progression of the disease. Thus, strength assessment of muscles around the knee joint forms an important part of evaluation of osteoarthritis of knee. Handheld dynamometer is an objective, reliable, and validated measure of muscle strength. It is small and portable and measures strength objectively in kilograms, pounds, or newton. The handheld dynamometer is much less expensive and efficient to measure the isometric muscle strength at a particular angle as compared to the isokinetic machine. The isokinetic machine being costly and bulkier, the HHD becomes an easier, less cumbersome option. Measures isometric quadriceps and hamstring strength assessed using the baseline hydraulic handheld dynamometer. Radiographic classification of severity of osteoarthritis of knee using Kellgren-Lawrence scale. Were performed with the subject in sitting position on a high plinth with the thigh horizontal and the knee joint at the edge of the table with a hip knee 90-degree angle. The subject was asked to hold the edge of the plinth for stability. The examiner was seated in front of the subject with one of the feet against the wall to be able to better resist the muscle contraction. The handheld dynamometer was held perpendicular to the limb surface and turned so that the examiner couldn't see the scale during the testing. The readings were noted by another assessor. Prior to testing, subjects were given a practical trial of one submaximal contraction in order to familiarize the subject to the testing procedure. After 2 minutes of rest, for quadriceps testing, knee was positioned in 90-degree and maintained in the position using a standard goniometer. The HSD was held on anterior part of lower leg above the talotibial joint line. Patients were asked to do a maximal isometric contraction held for 5 seconds. For hamstring strength at 90 degree of knee flexion, the HHD was held on the posterior aspect 1 to 2 centimeters above the lateral malleolus. After a rest period of 10 minutes, the readings were obtained from the other leg. From each leg, 3 readings were recorded for both quadriceps and hamstrings with 1 minute rest after each contraction. The mean of the isometric strength values were recorded in kg and the ratio was obtained by dividing the mean quadriceps to mean hamstring strength. Classified on the basis of stage of OA according to the Kellgren's-Lawrence scale by a radiologist of the institution. The examiner was blinded. The obtained data of quadriceps hamstrings ratio was then correlated with the grade of osteoarthritis. Discussion: quadriceps to hamstring strength ratio. The mean QH ratio in group 1 was 1.425 with standard deviation of 0.385, whereas the QH ratio of subjects in group 2 was 1.47 plus minus 0.21. The difference between the two means was compared using the Mann-Whitney test, which showed a significant difference at 95% confidence interval. In the present study, the quadriceps to hamstring ratio in patients with osteoarthritis of knee was less as compared to the age and gender matched controls. This result is consistent with the study by Karen W. Hayes and Judith Falconer In their study on 43 patients with physician-diagnosed osteoarthritis of knee, they assessed the QH ratio using the handheld dynamometer, and the mean QH ratio in patients with OA knee was 1.43 plus minus 0.39 as compared to the healthy adults in whom the ratio was 2. This decline in the ratio was attributed to pain which caused the reflex inhibition and thus reduced strength. By Kathy Hall, Karen Hayes, and Judith Falconer, the effect of pain and joint enlargement was studied on the QH ratio in patients with ONE as compared to healthy adults. In a group of 21 patients, the QH ratio was studied and compared to age, gender, and dominance of leg matched controls. The QH ratio was compared in both the groups using the unpaired t test and found to be significantly different. Further, QH ratio was correlated with age, pain, and joint effusion, and only joint enlargement correlated to QH ratio in the ONE group. The study concluded that joint enlargement may have an effect on the QH ratio in ONE individuals, while age and pain did not show an effect on the ratio. QH ratio and KL grade. Rodorfer et al. Did an extensive study on OA knee patients to assess the disparity in muscles of the thigh between the symptomatic and asymptomatic knee across various grades of osteoarthritis of knee. In a sample of 3,809 subjects with osteoarthritis of knee, the scores of isometric strength of quadriceps and hamstring was compared using covariance model between symptomatic and asymptomatic knee. The Kellgren-Lawrence Grade and Pain Subscale of WOMAC, Western Ontario McMaster University's Osteoarthritis Index. The study concluded that there was no direct association between strength and radiographic severity of OA, but knee symptoms, particularly pain, is a relevant determinant of muscle strength of quadriceps and hamstrings. The results of our study was consistent with the above study, wherein there is no linear association of the quadriceps to hamstring strength ratio and Kellgren-Lawrence scale of radiological severity of osteoarthritis of knee. Betson J. et al. Showed that radiographic osteoarthritis is an imprecise guide of pain and disability. Another study by Muraki S. et al. Concluded that women tend to have knee pain even without radiological joint space narrowing, unlike men, in whom knee point pain is strongly associated with joint space narrowing. The ratio of isometric strength of quadriceps to hamstring is significantly lower in patients with osteoarthritis of knee as compared to healthy adults. There is no correlation of quadriceps to hamstring strength ratio and radiological severity